Good morning. My name is James Stanger. A fairly hot Australian summer this morning. The video today I would like to talk about is a paper published a couple of weeks ago in Human Reproduction Open entitled "The Declining Efficiency of IVF in the USA." So here's the paper published in Human Reproduction Open. This is an open access journal, and here is the URL. The main author is Norma Gleicher. As you'll see, is not a keen advocate of PGT. So I might just move this over to here, just makes it a bit easier. I apologize for that. Okay, so the study question here was, the authors asked, has the efficiency of IVF cycles in the USA declined between 2012 and 2021, which is the last published data for the US IVF data set? The answer to the question is, he believes that it showed a continuous linear decline between 12 and 21. It was based on what previous studies have reported. The live birth rates after IVF increased till 2010, but subsequently declined, potentially due to the introduction of IVF add-ons and changes in clinical practice. And it's this concept of add-ons that Gleicher is normally interested in, which we'll focus on in this paper. So one thing that Human Reproduction Open does do is do a lay summary for readers. And for that lay summary, the authors have said, we've analysed US national data to see how IVF has changed over the past decade and found that despite a sharp rise in the number of IVF cycles, the chance of having a live birth in any given year has steadily declined from about 29% in 2012 to 22% in 2021. Live births increased in absolute numbers, but not as quickly as treatment volume. This downward trend in cycle efficiency coincided with major shifts in IVF practice, including expanded freeze-all strategies and the widespread use of related add-ons, including PGT-A. These findings suggest that while IVF is more common, it is becoming increasingly less efficient, underscoring the need to reevaluate routine clinical practices. This is just my take on the data which I'll present in a minute. So their argument: the utilization of add-ons significantly increased further and often with absolutely no evidence of efficiency. Pre-implantation genetic screening for aneuploidy, PGT-A, is a prime example, since PGT-A does not improve IVF outcomes, and considerable concern has indeed been raised that in a certain subgroups of patients, PGT-A may in fact adversely affect outcomes. And they gave a couple of references there. Moreover, with aggressive entry of private equity investments into fertility practice in recent years, because of the field's growth expectations, IVF has also undergone major structural changes in how and by whom IVF is offered, and I'll talk about this reference in a second. And lastly, we've recently demonstrated that ownership of IVF clinics affects PGT-A utilisation, an observation which likely also applies to the utilisation of other add-ons. So, two views. Early on, IVF was uncomplicated, with most cases proceeding to a fresh embryo transfer on day 3 in cleavage stage, or on day 5, which is blastocyst stage. But the introduction of time-lapse monitoring of PGA genetic embryo analysis, plus donor oocytes and oocyte freezing for fertility insurance, plus genetic screening of embryos, that's in PGT-M and PGT-P, plus same and single-sex clients, have changed the trends to oocyte and embryo freezing and frozen embryo transfers, with fewer fresh transfers. So, if the aim of IVF was to help clients have children, and with knowing that all the effort, energy, costs and risks occur with the treatment of cycles and oocyte recovery, that's where all the effort goes into, then the primary KPI or key performance indicator should be babies per oocyte collection or babies per cycle started. But these days, there's very little information on how many cycles are started and cancelled. And so these two basically run side by side, with this one being a little bit lower than that. Yet many of the new treatments act to restrict embryo transfers only to those with high quality embryos, and also to have fewer transfers. So it's now quite common for 10-15% of people growing embryos to day 5 and having PGT-A will find they don't have any normal ones, and the embryos are then discarded. The couples are asked to go away, but there's still been a KPI, that is for an egg recovery tricycle. And also, with PGT-A, there's often the embryos are frozen, and they're often delayed for quite a few years, particularly with fertility preservation. And if you look at the cumulative live birth rates, where all the transfers associated with egg collection are expressed as a live birth per collection, which is basically this KPI, right? They all demonstrate that these new treatments have the same KPI as doing nothing. In other words, all this activity is looking at high quality embryos and discarding the people that won't fall pregnant, basically just dismissing those. But they're not adding any more babies to the system. In fact, they're not saving embryos from being discarded. So if the new add-on treatments such as PGT-A do not increase live birth rates, what is their value? Well, what they do is decrease the number of transfers to live birth, but they do decrease the miscarriage rate by about half, from about 20 to 10% or 15 to 7%. But it's not one of the KPIs, since what you're missing out, people that miscarried in these cases now not having a transfer. But it doesn't change the KPI live birth per cycle. Also, many older clients are having with a decreased chance of pregnancy. So that number is increasing. So that will, in fact, lower the KPI because there's more treatment cycles with fewer babies. But the use of donor oocytes will increase the KPI because basically you're having more babies per treatment cycle, except that they do not have an egg collection. So how do you then have a cycle started and that will increase the KPI? So there's some question about the stats if the older women having donor eggs, whether that is considered a cycle started because there's no egg collection. That one has been done before with the egg donation. So here's the data that the authors basically took from the US MPU started. You can see the cycle started, which basically means pickups have risen in 10 years from 170,000 to 413,000. That is like a 234%. That is just in 10 years, right? And the number of transfers has increased, but you can see here the number of transfers has not increased in the same amount. So, and if you look at the number of cycles where embryos are being frozen, in fact, it's a little bit hard to know exactly whether this is only banking cycles or cycles with transfers and banking. So I think they may be at a double dipping here. These are the babies that have been born, live births, and I assume so. These are not deliveries; these are babies. So twins will be counted as two, and that has increased by 180%, which is good. But the cycle efficiency, which is live births per cycle started, you can see for 29% has fallen to 22.2. So the authors say the cycle efficiency was defined as the number of live births reported in a given calendar year divided by the number of IVF cycles initiated in that same year. It's basically what I would have called in my good old days of running embryology labs, my efficiency index or productivity index. This measure reflects the probability that a patient starting an IVF cycle in a given year will achieve a live birth from that cycle, even though it's using the year data. The increased percent represents percentage change from the start from 2014 to 2021. But if you go back to the CDC data set, looking for the IVF data, you can see that going from 2013 to 2022, which I find rather interesting because that 22 data is here, but it's not in the publication. You can see that basically the proportion of these are the cycles of ART, the result in live birth. This is the pregnancy rate, the efficiency. And you can see basically it's increased maybe about 2%, but the real change has been in people over 38 and over 40. That has been the real change. But the important one here is look at the percentage of embryo transfers resulting in live birth, patient agent by egg source. This is for women using their own eggs, and you can see how it falls away very quickly from 40 onwards, but in fact the change is really falling from just over 36. But where you use donor eggs, usually from women under 30, the pregnancy rate is virtually the same. It only falls just maybe 5%, even for women over 45. This is almost a 40% chance. So if you're over 45 and you're having donor egg transfers, you basically have got one chance in 3, one chance in 2 having a live birth. It's quite remarkable. And if you look at the type of transfers, The blue line is the number of fresh embryo, the orange line, for embryos from fresh patient eggs. That has gone from 90,000 down to around about 50,000 per year. But the use of donor eggs, fresh donor eggs, this one here is almost collapsed. In other words, all egg donation now is using frozen eggs, and that has increased from about 10,000 to about 22,000. But the big change has been in this one here, embryos from frozen patient eggs or embryos, where basically you can see that whereas before in 2013, there was half the number of fresh transfers, it's now basically 3 times the number of fresh transfers. And so this is a huge transformation in this 10 years of embryos being put back in frozen cycles. And there's just one other thing I just need to do. This is looking at the number of embryos being transferred, something the author sort of mentions a little bit. If you look at the percentage of embryo transfers with single embryo transfers, what we call SET, single embryo transfers, it's gone from about 30% in 2013 to around about 85% in 2022, which is quite remarkable. And but this actually is transfer cycles, so that a lot of that will be blastocyst transfer. Right? And a lot of these cases that wouldn't have had a blastocyst have actually just been discarded. So it's quite a bit of an artifact when you look at the pregnancy rate, percentage of embryo transfers that result in live birth, singleton, twins, etc. You can see that the number of singleton pregnancies have risen dramatically from about 25% to around about 35% in that 10-year period. And the twins and triplets have actually plummeted. And that is actually good news. And just lastly, just a percentage of cycles attempted. This is the reason they're given, and they said there could actually be more than one cycle. But this is the big change. Egg or embryo banking, freezing for fertility preservation and for egg donation. And the other 2 aspects of age, which are related to diminished ovarian reserve and male factor fertility, they're kind of related. They've also increased quite a lot. PGT has gone up 20%. But what's interesting, all the other ones like endometriosis, uterine factors, tubal factors, represent now only about 10% of the reason why people are having IVF. So the big shift has been from true fertility cases like endometriosis and in blocked tubes to more embryo handling actually to do with age. Okay, so their argument. The utilization of add-ons significantly increased further with often absolutely no evidence of efficiency. Pre-implantation genetic testing for euploidy is a prime example, since I've had this argument before, this slide before, since PGT-A does not improve IVF outcomes, and considerable concern has indeed been raised that in certain subgroups of patients, PGT-A may even adversely affect outcomes. So I need to look at 2 things here. One is time-lapse embryology, and the second one is PGT-A. This was a study done in 2023, published in The Lancet, a randomized trial demonstrating that if you grow embryos in a uninterrupted time lapse, where the embryos are basically put in very small drops and left there for 5 days and photographed every 15 minutes, compared to growing embryos in dish and being expected every day at particular times, you can demonstrate that neither time-lapse based embryo selection using this EVA test or uninterrupted cell culture in a time-lapse incubator improved clinical outcomes compared to routine methods. Widespread application of time-lapse monitoring fertility treatment with the promise of improved results should be questioned. So even though, so they're basically saying that in fact the time lapse, there was concern that taking embryos out once a day to look at them and grade them and the time it takes to do that adversely affected the embryos. But this study demonstrated that that is not true, that the chance of pregnancy is the same, and that the small time taken out to assess embryos is very minor and compared to the overall time. But the time lapse, where you have to have a very small system, it's being photographed all the time. No one really knows the impact of photography on the embryos. Basically, it makes no difference. Time lapse are expensive. They do save the embryologist some time, but there's a huge amount of data. So there was a paper in FNS reports in 2025 The object was to compare embryologists' confidence levels and grading concordance when assessing embryo morphology with time-lapse images compared to direct observation under a microscope. And the conclusion was the embryologist maintained high confidence in morphology assessment using time-lapse systems, even under time constraints. Inter-observer agreement for embryo grading assessed by comparing the same embryo's grading using time-lapse was comparable to previously reported levels of agreement for traditional morphology grading. In other words, everyone has been bagging embryologists. They're all over the place and they're bloody hopeless and da-da. When you actually go back and test them using a time-lapse system where they're all looking at the same thing, they in fact are very good. But conversely, you could argue that the time-lapse system is as good as embryologists with more than 20, 30 years experience. These findings highlight the feasibility of flexible or remote assessments without disrupting embryo culture, enhancing workflow adaptability, and paving the way for advancements in artificial intelligence integration. So the point here is embryos will say it's not making anything better, but on the other hand, it's not making it worse. And it does provide for opportunities for further advance in the field. So does time-lapse make the grade? This was an article in 2025, open access original article. The crucial performance indicator for embryology labs is efficiency. PICO showed that with continued usage, the mean embryo assessment time-lapse was approximately 15 seconds shorter than the standard grading. Whether this small improvement in time burden has an overall impact on embryologists and laboratory efficiency is yet to be seen. The answer is probably no. But it's important to keep in mind the ultimate goal of fertility centre is improved live birth rates. Current published evidence does not show that time-lapse technology improves clinical outcomes over standard embryo grading. Theoretically, the benefits of having access to more data, keeping embryos undisturbed in the incubator, and decreased touch points may be associated with improved outcomes. Some believe that time-lapse may even help predict embryo ploidy. However, existing randomized trials and systematic reviews have failed to demonstrate any clinical advances of time-lapse embryology. But they're just going to show where you may be going in the future. What do they offer? Well, time-lapse systems allow an insight into the developing embryo that few static observations can achieve. As you say, you can see, like for instance, with pronuclear development, subtle changes, the way the pronuclear development that you can't act just by doing a 17-hour time check. We all know that there are key changes in embryo development that should occur at specific times, and astute observations at these times can tell an embryologist all they need to rank the embryos in a cohort for their suitability for transfer. So really the whole business is ranking embryos one to whatever to know which is the best embryo to put back first to get the highest chance of pregnancy. And what I'm making the point here is that there are certain checkpoints when the embryo has maximum, when the pronuclei disperse, when the embryo cleaves from 2 to 3 cell, 4 cell, 8 cell, etc. When you first start to see the blastocellular cavity, these are critical checkpoints. And if you know which time to look at it, an astute embryologist can tell whether an embryo is dividing fast, the correct time or so. However, time-lapse systems generate huge amounts of data that allow algorithms to be developed to approximate the embryo's skill in which embryos can be transferred first, but they're highly dependent on the data set that they've been generated from, and they act to restrict embryology development from trying new systems. The huge data may allow new insights in the future that may change the way we grow follicles or harvest eggs or make embryos. This may increase the KPI in the future. That may also allow more activity with fewer staff and less burnout. It will not deliver more babies per cycle, maybe only sooner. And let's just go look at the PGT-A. There's been a couple of papers. This one was in July 2025, looking at the cumulative live birth rates. This one's for recurrent pregnancy loss between PGT-A and conventional IVF, and they concluded that PGT-A did not significantly improve the cumulative live birth rate or shorten the time to live births in people with recurrent pregnancy loss. Further research is needed. So the results that they're talking about was after 3 single blastocyst transfer cycles, there was no significant difference observed in the conservative cumulative live birth rate between PGT-A and standard IVF groups. Similarly, the optional cumulative birth rate after 3 transfer cycles showed no significant difference between the two. However, and this is important, however, the time to live birth was significantly longer in the PGT-A group and I actually don't understand why that is. It should be the other way around. But it tells you that the people doing the embryo selection were probably very astute. And then just looking at the benefits of doing PGT-A, there's also from another Chinese group. They seem to be dominating this area at the moment. The PGT-A does not increase or decrease cumulative live birth rate per egg recovery. Nevertheless, it's effective in the infertile populations with specific indications. PGT-A reduces complications associated with multiple gestations. Okay, fair enough. Basically, because I think they're putting fewer embryos back to transfer. So a total of 4,000 PGT-A cycles were matched with a similar number of 10,000 non-PGT-A users. A significant reduction in the cumulative live birth rate was observed using PGT-A, down 28%, down from 31. However, women using PGT-A did have higher first transfer pregnancy rates. So the first transfer in this case had more pregnancy, 63 to 46. Live birth rate was, well, I don't actually understand that one. That's actually per cycle. Lower chance of miscarriage, 12% down from 20%. A lower chance of preterm from 8% down from 17%, and a lower birth weight, 4% down from 19%. So in this study, this is published in December 22, so we've gone back a couple of years. PGT-A was associated with a decreased cumulative live birth rates amongst patients who had blastocysts available for embryo transfer or PGT-A, except for those women over 40. The negative association of PGT-A use and clinical live birth rate for cycle study was especially pronounced for women under 35. So this is another case where, in fact, the PGT-A might be benefiting some people but not others. And if you're in terms of looking at efficiency, it depends upon what makeup of your population is. So if you have lots of women over 40, PGT-A might give you a live birth rate per cycle started. But if you have a lot of clients under 35 doing PGT-A, then probably will lower your efficiency. Okay. So let's just one last one. This is a similar one. PGT-A utilization in clinics does not improve live birth rates, but relates to IVF centre ownership. And this is another thing that Norman Gleitch was talking about. There's the change of ownership from fertility centres to corporate entities. PGT-A overall reduces live birth chances in IVF, with the risk of adverse outcome effects increasing with growing PGT-A utilisation in primary women under 35. So a lot of people are saying that under 35 PGT-A is bad news. However, equity and venture capitalist ownership favours the use of PGT-A utilisation in comparison to private physicians and academic, hospital or military citizen ownership. These findings suggest that the intervention strategies should be to reverse excessive PGT-A utilisation. And this is just the chance of live births in 2028 US population against PGT-A utilisation by how much of the ownership is owned by private capitalists. So we'll just so it's by age. So this column here is this the utilisation of PGT-A. So here they had hardly any PGT-A, and their live birth rate for under 35 was 50%. But here's a clinic doing almost 80 to 100% PGT-A, right? And their birth rate is 45%. But you can see here for women under 37, the birth rate was significantly higher when there was very little PGT-A being done only on selected clients, not university right across the board. And there is a suggestion that people over 43, that maybe you may actually do better if you have 100% of clinics just doing 100, where the clinic's doing 100% of the cycles using PGT-A. But basically, I think I just need to come back to this KPI, and it just depends how you look at it. So this is the same data that was presented early on. This is the live birth rate per cycle, which is falling, as we said before, from 29% to about 22%. But if you look at the live birth rate per embryo transfer, you can see that this has actually increased quite a lot from about 28 to 38% to about 45%. So all the live births can only come from embryo transfer. So even though they're doing more and more cycles, and therefore in terms of efficiency, they're getting fewer babies per cycle, that's basically telling you there's a whole lot of pickups that don't go to embryo transfer. And if you look at the number of embryo transfers per cycle, you can see in 2012, it was about 78%, but by 2020, actually, I think I've got that wrong. I apologize. That should be 2012 to 2021. Don't need to use Excel, hopeless. You can see that the big change is that we're doing a lot more pickups and doing fewer transfers. So my comments. The point the authors are making is that there is, I think I just move this again, I do apologize. The point the authors are making is that there are only a couple of embryos in each and every cohort of oocytes that have the potential to produce a baby. Many of the add-ons, as the authors call PGT-A, etc., may identify and transfer these embryos sooner and with fewer miscarriages, but the good embryo will ultimately be transferred regardless of any testing. Thus, the KPI is the same. The authors express concern that many clinics not only are not owned by fertility specialists, but by corporations and big business. Their interest is to shareholders to increase revenue wherever possible, and this may include promoting many add-ons such as PGT-A. They do cite increased pregnancy rate per transfer, often by cancelling transfers of clients without good embryos. But this is a different KPI because this is talking about efficiency of transfer, whereas the authors are talking about efficiency per cycle where all the activity of the clinic is done. The authors also cite embryo banking, and single embryo transfers and the use of donor sites as changing the dynamics. Donor oocyte use in creating embryos in older women must produce more babies than where the client uses their own oocytes and used with poor outcomes. Also, reducing the number of embryos transferred from 2 to 1 will reduce the number of babies born, even though the pregnancy rate may be going up. So, note the incredible increase in activity, 230%, without generating any more babies, is making some owners and some supply companies like the media manufacturers, etc., very wealthy. But is it increasing the stress and burnout of staff, especially laboratory staff? This will increase the cost and the likelihood of errors and litigation. Unfortunately for authors, one cannot put the genie back in the bottle, but wise heads may soon start to temper the enthusiasm for add-ons. So you may find that after a while, clinics will start to recommend their clients not to have PGT-A, just to put the embryos back and see what's going. I have to say, though, that generating fewer miscarriages is a really powerful incentive to do it. And from that point alone, I've never been a great fan of being in PGT-A for everyone, but I can see the value of it in reducing miscarriages. Okay, so just the last slide. Unfortunately for the authors, one cannot put the genie back in the bottle, but as I said, wise heads may start to temper the enthusiasm for animal like PGT-A. The one genie that is starting to take off is polygenic testing. That is where you're testing risk traits in tested embryos of DNA. The reason that this genie is going forward is these new clients are fertile clients. If that takes off, and it will, the numbers starting IVF and using PGT-A will just explode. We've seen what happens with the oocyte freezing. At PGT-P, give it 10 years and you'll be doing twice as many cycles, and nothing to do with infertility. It's all about polygenic testing. But what will that do to the KPI? It'll probably make it less. Okay, I think I might finish up. My name's James Stanger. I'm an embryologist with my 50 years experience. I'm not a medical person, and this information is not medical advice, but hopefully it might help you in knowing what questions to ask about your treatment with your doctor and maybe helping to understand the advice you receive. If you like what I'm doing, press subscribe or make a comment and press like. But more importantly, I just wanted to make a comment that this is being funded currently by my third aid online EQA program, right? We test the embryos, test the staff for their skills. But I'd just like to thank you for your time. IVF, I know, is a personal experience, is a personal journey that involves the action of many techniques, philosophies, arguments of staff, and money. But it helps to understand all aspects of that journey. I hope this information may be of value. Tell others about it if you like, and press subscribe. At that point, I'll say thank you very much and say goodbye.